Bismillahirrahmanirrahim. Myself Dr Tayeb, and today today I am going to present a case that presented to our medicine department 2 months back. So first of all, introduction about the case and the patient. Patient was 41 years old, female, resident of Gizar GB, housewife, no known comorbids, presented with complaints of severe headache from last 6 days along with vertigo. Headache was sudden in onset of severe intensity, continuous in nature, generalized more at frontotemporal region, no aggravating and relieving factors associated with nausea, and 2 to 3 episodes of vomiting that was non-projectile with no sign of hematemesis, and headache was not associated with fits, loss of consciousness, neck stiffness, diplopia and fall. For vitals of patient, blood pressure was 180 by 110 on presentation, and patient was not on any antihypertensives before and was not known case of hypertension. Pulse was 98, saturation was 95, respiratory rate 18, temperature 97, and all the baselines were normal. On examination, on general physical examination, patient had multiple well-defined brownish papules on nose and around cheeks in a typical butterfly manner, and a fibrous shagreen patch was noticed on left forehead area. And this is a clinical picture of patient and taken after proper informed consent. And this was a shagreen patch on left front forehead area, and these are the brownish papules known as angiofibroma or adenoma sebaceum. On systemic examination, palpation of abdomen revealed palpable mass with prominent border of the for that CT abdomen was advised. That showed a huge retroperitoneal mass in right sided abdomen, displacing and pushing the right kidney inferior medially, representing large retroperitoneal mass, that is lymphangioliomyomatosis, and multiple fatty attenuating focal mass lesions in renal cortex of bilateral kidney, representing angiomyolipomas. This was a CT abdomen of the patient representing showing angiomyolipomas and lymphangioliomyomatosis. For headache, CT brain was advised that showed resolving frontal and intraventricular hemorrhage and subependymal calcified hematomas along the bilateral lateral ventricles. So these were the hematomas in bilateral ventricles that is typical for the diagnosis of our patient. That was diagnosis, and I'll tell in the end. CT cerebral angiography, we also advise CT cerebral angiography because patient had severe headache that was not resolving even after controlling the blood pressure and not responding to medication. So CT cerebral angiography showed a saccular aneurysm in anterior communicating artery. For that, neurosurgery department was consulted for possible intervention. This was a CT cerebral angiography of showing anterior communicating artery aneurysm. Echocardiography revealed good LV systolic function with hypertrophic cardiomyopathy and showed no rhabdomyomas. On ophthalmic examination, no iris nodules were seen, but there were retinal hematomas of left eye. Patient also had a strong family history of similar clinical condition, mother and 2 sons. Mother had angiofibroma phase whose workup was not done and died at the age of 50 years. No record available of that. Elder son who had angiofibroma phase and no workup was done and died at the age of 14 years. Presently younger son of 7 years of age who have same findings and have been called by our medicine department for workup and possible treatment. Rest of the 2 daughters were healthy with no symptoms. For a diagnosis of according to operative diagnostic criteria that I'll explain later, 2 major or 1 major and 2 minor features, I'll explain the features after, make definitive diagnosis. Our patient had 5 major features including angiofibroma, shagreen patch, angiomyolipoma, lymphangioliomyomatosis and renal hematomas. On the basis of above finding, diagnosis of tuberculosis were made in our patient. Yes, tuberous sclerosis. What is the short detail about tuberous sclerosis? Introduction: tuberous sclerosis is an autosomal dominant condition affecting 1 in ratio 10,000 people in general population. Second most frequent neurocutaneous syndrome after neurofibromatomas. Like neurofibromatosis, majority of features seen in tuberous sclerosis complex are neurocutaneous. Pathophysiology. In tuberous sclerosis, mutation of tumor suppressor gene that leads to loss of function, leading to unchecked cell growth that leads to tumor development. And in the tumor suppressor genes that are responsible in tuberous sclerosis complex are of two types: tuberous sclerosis 1 and 2. One is tuberous sclerosis 1 gene is on chromosome 9, encodes hamartin protein, and 2 is on chromosome 16, encodes tuberin protein. Out of these two genes, the most commonly affecting is tuberous sclerosis 1 gene. Features are, as this tuberous sclerosis complex is a multi-system involvement disease, so features are almost from all the systems. First is cutaneous, that is most common and most easily finding is adenoma sebaceum, that is facial angiofibroma around nose and cheeks, that is typical in butterfly distribution. Ash leaf spots, that is hypopigmented macules on trunk and extremities. Shagreen patch, that is flesh colored papule with orange peel appearance, and subungual fibroma. Other system that tuberous sclerosis complex involves is the cardiac system, that is cardiac rhabdomyoma, that presents in more than 50% of affected individuals and may cause symptoms of mitral regurgitation and congestive heart failure. Involvement of neurological system is developmental delay, epilepsy, autism, intellectual impairment. Fibromas may also develop in CNS where they calcify typically in periventricular area. Involvement of renal system leads to causes renal cyst, angiomyolipoma, and renal carcinoma. Ophthalmic involvement causes retinal astrocytoma that tends to become calcified over time. Involvement of pulmonary system causes cystic pulmonary in as many 40% of patients. Dental involvement causes gingival fibromas. GIT involvement, hematomas and polyposis of stomach, intestine or colon, and hepatic cyst. For diagnosis of tuberous sclerosis complex, first we will do ECG to look for cardiac rhabdomyomas that can cause ventricular hypertrophy and arrhythmias that we will find in ECG. EEG for seizure activity, because epilepsy is there is a triad of epilepsy, adenoma sebaceum and Shagreen patch of tuberous sclerosis complex, but epilepsy is not very common in all the patients. So EEG for seizure activity. Echocardiography to look for rhabdomyomas, that is common in apex of left ventricle. Abdominal MRI to look for renal cyst, angiomyolipomas and carcinomas. Contrast CT MRI for tumors, that are giant cell astrocytoma and enlarged ventricles, tumor in periventricular area causing hydrocephalus. Diagnostic criteria. For diagnostic criteria, it is divided into major features and minor features. Major features includes angiofibromas, ungual fibromas, Shagreen patch, multiple renal hematomas, subependymal nodules, subependymal giant cell astrocytoma, cardiac rhabdomyoma, lymphangioliomyomatosis, and angiomyolipomas. And for minor features, gingival fibroma, dental enamel pits, retinal achromic patch, multiple renal cysts, and non-renal hematomas. Updated diagnostic criteria according to recommendation of 2012 internal tuberous sclerosis complex consensus conference. 2 major or 1 major with 2 minor features makes a definite diagnosis. So in our patient, following this criteria, our patient met 5 major features and made a diagnosis. For management of tuberous sclerosis complex, as epilepsy is also feature of tuberous sclerosis complex, so severe controls with anticonvulsants and an FDA approved mTOR inhibitor, a mammalian target of rapamycin, that is everolimus. This is a FDA approved treatment for tuberous sclerosis complex. And next is removal of angiofibromas, that is laser treatment or electrosurgery, and surgery in case of obstructive hydrocephalus with increased intracranial pressure. Thank you, sir.
Case is very interesting, but we managed this patient not well. You know, this patient was admitted in our ward with
Yes, sir.
mass, large abdominal mass, suspected renal mass.
Yes, sir.
Later on, we found she had multiple these issues. Her blood pressure was high.
Yes, sir.
So we were suspecting possibly it could be tuberous.
Yes, sir.
So we called medical department for help. Medical department also did a delay, quite delay. And in this delay, she developed stroke. And I think she died.
No, sir.
Survived?
Yes, sir. She is okay.
She was managed here and
Yes, sir.
and she referred to
for
further because the treatment this everolimus is very expensive.
expensive. Yes, sir. We tried to manage
You can say almost 30 tablets
for 1 lakh, sir.
for 1 lakh.
1 lakh plus, yes, sir. 30 tablets.
12 lakh. 12 lakh for 30 tablets.
Yes, sir. 30 tablets.
1 month course.
You could save her stroke.
That's why she referred to a KUH for further treatment and assistance as well. Luckily, she reached there.